My name is Paul Mbaka. I'm the Assistant Commissioner, Division of Health Information at the Ministry of Health. The Division of Health Information is charged with implementing both the health information and digital health strategies of the Ministry of Health. Everything that we do generates data and information. We have to pick up this data for the purposes of planning, accountability, but as well as optimizing service delivery. One of the areas where the Ministry of Health offers services is in the community. And it is as well that even in the community, the Ministry of Health has decided to digitize. We believe that if we digitize at the at the community level, we will significantly ease the work of our community health workers that we commonly call the village health teams or the VHTs. The iCoHS project was very instrumental in supporting the Ministry of Health strategy to implement a digitized community health information system. It served as a catalyst or a trigger by first of all demonstrating that this dream we have of a digitized VHT is actually something that can be realized.
iCoHS stands for Intelligent Community Health Systems, and it's a program of over 3 years since 2019 to 2022 to strengthen community health workers, which UNICEF feels is very important to reach every child. UNICEF works in Uganda to reduce child mortality. At the moment, 64 children per 1,000 die every year. This figure is very high when you think of the SDG target as being 25 per 1,000. And to reach those children, you need community health workers. So iCoHS has enabled us to strengthen government services for community health workers to reach every child. It's very important for development partners to work in consortium, and iCoHS has supported a consortium of 4 to 5 partners around strengthening community health data systems. This consortium joined together and has been supporting the Community Health Toolkit to equip community health workers with information that they need to identify high-risk children, but also to collect information from them about how many children they're seeing, so that the consortium and UNICEF know where those children are, so that we can reach them and support the government to reach them to reduce child mortality.
So I've been really honored to work on iCoHS, specifically Objective 3. In order to deliver on Objective 3 here in Uganda, UNICEF contracted a consortium of partners led by Living Goods. So Living Goods is the prime in this consortium, and our role is to do project management and coordination. In the consortium, we also have BRAC. BRAC is the deployment lead, and their role in the consortium is to train the VHTs within the 2 districts where we are operating. Then also we have DataKind. DataKind is the analytics experts on this project, and their work is to really innovate around data science techniques that we can use to be able to draw insights from the data that is coming in from the community. Then we also have MEDIC as a part of the consortium. MEDIC is the developer of the community health toolkits, which we are leveraging on for this project. So the Community Health Toolkit is one of the technologies that Ministry of Health Uganda is adopting for its electronic community health information system.
MEDIC has been working as a technical steward of the Community Health Toolkit. The CHT is a platform. It's a platform that's built primarily to support community health care workers as they deliver care in the community. The platform is an open source platform. It's a digital public good. It's designed to be available to partners and to national ministries of health around the world. The tool is capable of analytics on the web. And so for district officials, for Ministry of Health officials, for partner officials, wherever you are in the world, you can access the analytics of your community health care program.
For this project, we are working in Ntungamo and Lamo. Ntungamo and Lamo were selected out of a list of 5 districts where we conducted a baseline assessment.
We did a bottlenecks assessment, which was highly qualitative and quantitative, so it was mixed methods. We held focus group discussions at the district, where we took them through some of the tools that we used at the BNA. The BNA was guided by the Ministry of Health bottlenecks implementation approach, so we adopted that approach. We did the CHW AIM tool that was developed by UNICEF, so it measures the maturity of the CHW programs. And then we also used the CHW digital maturity model that was co-developed by Living Goods and Health Enabled. We reviewed the DHIS2 data to ensure that we were able to capture the bottlenecks that were existing at that level, because then that was actually key in ensuring that we develop a system that addresses gaps at that level.
HCD essentially stands for Human-Centered Design, and Human-Centered Design is a methodological framework that requires that you involve end users first. Without going straight into trying to propose technology interventions. So that's what human-centered design is.
For this project, we are working with a total of 500 VHTs. 200 of these are from Alamo and 300 from Tungamo. With the support from UNICEF and Rockefeller, we have been able to equip the VHTs in both districts with mobile phones.
BRAC Uganda is mandated to lead on the field deployment of the tool, which really starts with the training of the VHTs, coming up with a cohort of TOTs at district level, and through the different channels of support that we provide to the VHTs after the training has happened. The deployment took a phased approach. We had the first phase where we did the training of the VHTs. We were able to have the trainings conducted at both the district level and also at the sub-county level. At the district level, we focused on the TOTs who come from the district health team and also the facilities. We had at least 2 days of where people were trying to get familiar to using a smartphone. For those who had never used a smartphone, which is the majority of the participants that we are reaching had never used a smartphone before. After that, we then had the VHT trained on the component of the VHT application, which is the iCoHS. After they went live, they started the actual usage of the VHT application to do their household visits, to do assessment of the sick children at community level, and also provide treatment and also referral for the under 5 children.
Within the iCoHS consortium, DataKind's main role was to use data science-driven analytics to support the ministry's health system managers monitor the quality of the data that's entering into the electronic community health information systems, as well as the integrity of the underlying data management system. We developed what's called the Data Observation Toolkit, or DOT. DOT monitored data, and the resulting high-quality data sets really increased the trust and confidence in the data that's generated at the community health level.
The application is able to work in an offline setting. This is critical for our partners, for the community healthcare workers especially. Some of them work in areas where internet and other infrastructure are not available. To be able to do continued service in the community without needing an active data connection, that's a significant game changer for the work we do.
In the sub-counties that we have had this intervention, there's a big success story as far as VHT reporting is concerned. At one point, we had the VHT reporting rate as low as 30%. But now in the intervention sub-counties of Palabek, Game, and Lamont Town Council, it is 100%. That means we are not missing on any VHT reporting. because the hub has made their work very easy to report.
The data which is being collected by the VHTs, to me, is very holistic at the household level, covering quite a number of issues. We are seeing that this is a very good opportunity for us to use to inform the programming and planning within the Paris development model. So far as we talk now, the district has embraced this digitization very much. They are only looking at a time when the entire district is going to be trained. The VHTs has the phones and they pick the information at the household level.
I had to move to each household and see from their registers. So it required me to go there. It was actually like a house-to-house activity. That's how we would get reports. Then I would find so many issues in registers. Today, with digitalization of ICCM and VHT activities, I just monitor ICCM programs from my tab, from my phone. And I make follow-up on phone.
Those days when they come and ask for quarterly ICCM review meeting report, it would be very, very hard for us to collect that data because there were a lot of tools. The ministry brought a lot of tools, and those tools are supposed to be used by a VHT who may sometimes forget. So this application, like when they work on a patient, when they assess a client and treat them, the data will be sent direct to my tablet here, and then I receive it. So at the end of the month or at the end of the quarter, I don't need to ask them for a report. As long as they assess and send the data, the report will actually just come to my tab. So reporting has been improved, supervision is easy. I can find out who has not done what, then I follow them up easily.
One of our challenges as a district in implementing these VHT activities has been their motivation because of being volunteers. But the phone itself has been looked at as a very strong motivator for this VHT who has been volunteering for several years without being considered in terms of payment. Along the way, we realized that the VHTs, being from rural areas, not connected to the national grid, without access to power, there was an issue, the challenge to do with the charging of the phones. And then we sat with the teams from the implementing partners, and we were like, what should we do? And that's how we came up with the issue of being able to support these VHTs with the solar charging systems. To make it more motivating to a VHT who is volunteering, it doubles as a rating system.
Now, after after receiving the phone, it has made our work become very easy now. Because the register is here, it can remind us also when it comes the issue of follow-up, the postnatal care, antenatal care, the child that is due, the defaulter. So receiving this phone here has made us very, very, very easy work now.
Pachim pene makana wa ko bedong e community dong nan wa chalo ngo yo madon matiki ngej mo olo no mira ko bed ka miongo refresher training mo bene borwa ngeo chim eni kada wan mo kana no pun ngo puatio kede chon che mira ka ko bed ko me wa refresher training mo wek no ngo po wi wa gin no kana.
I would like to thank the partners. And I would like to tell them that, of course, working with government is not an easy thing. We are a bureaucracy. We cannot always run at the speed at which the partners would like, but we welcome the support. We encourage the partners to even support more so that we can scale in terms of the work that we have done.
To achieve the SDG 3, which all countries need to do by 2030, primary healthcare is the way to go. The international evidence base led by WHO and many other development partners say that primary healthcare is the way to achieve universal health coverage and to reach every child. iCoHS has made everybody excited about the potential of community health workers in Uganda. And through the consortium's work, the ministry has developed a community health strategy, a community health steering group under the Minister of Health, Through other development partners funding and also funding from 2 other donors promised, the work will continue to make sure that community health workers are central to the health system in Uganda.